All right, you guys good to go?
Yep.
Awesome. So we'll go ahead and wrap up Jeopardy a couple of ago. Who was here for that session? I know Stanley was there for part of it. Was anyone else there? I know Fema and Saya. Who was there for the last Jeopardy session?
I was there.
I think I was there. The one that was like a couple weeks ago.
Yeah.
Yeah.
Awesome. Cool. So then I'll hold off on going over the old ones. I have it set so that the old ones have already been used. We'll go over the ones that are unused. And then if we have time and anyone that wasn't there wants to go over some of the older ones, we can do that. So just a quick review. You guys can see my screen okay?
Yeah, we can see it.
Yep.
All right, cool. So All-Star Jeopardy. The categories are echo illusions, no flex zone, I'm drowning, the Iron Heart, and feeling blue, and then finally shockwaves. So these are the categories. Every answer must be answered as what is. And once again, we'll go over the ones that are untouched. We'll do Final Jeopardy. And then if anyone wants to go over some of the old ones, we can do that as well. I think there were 3 double Jeopardies. I think we used them all up already. And then once again, just credit to Rob to help me, who helped me put this together, but he's on nights. All right, who's up?
What is pass?
I think you used that answer last time, Mike.
It still works.
Shockwave for 400.
Shockwave for 400. 2 possible differentials for the pathology seen in this echo. There's a bunch, but you can give me 2. If you guys need the clue as to what the ultrasound pathology is, just let me know.
Blue.
You want to go ahead?
ASD?
Did you say VSD?
ASD.
ASD?
Yeah.
Yeah, so that the patient doesn't have ASD. It just kind of looks like it because of the its artifact, right? You're so far in the depth that it looks like you're losing out signal, but there's no ASD.
Got it.
So I'll give you guys a clue. The pathology seen in this echo is septal bound. So what you're seeing here at the septum is that it's with the respirations, it's bouncing back and forth between the left and right side. And that is not normal. So what I'm asking for are different septal bounds.
I can think of one maybe. What is
Yeah.
tamponade?
Yeah, absolutely. Right, so tamponade is going to cause a restriction on your right lateral wall, which with as you have changes in filling with Cicely and Dastley, and then also with inspiration and expiration, you're not going to be able to change your movement of that right lateral wall like it normally should, because it's very thin walled. Instead, you'll have to have the septum move back and forth between into the left ventricular space.
Oh, and I guess what is restrictive cardiomyopathy?
So not restrictive, because restriction is going to affect all the walls, right? So restriction is going to affect your septal and lateral wall. You're close. What is?
Constrictive?
Yeah, absolutely, right? Because it's only affecting the outer walls, right? And so you kind of go over differentials. Really what I'm thinking about, and really simplify, it can be a lot more nuances, but then at least how I break it down in my head when I see it in real life or in real time is RV pressure overload, RV volume overload, and you can try and differentiate the two if you really wanted to figure out what's causing the RV pressure overload or the volume overload. based on whether it's occurring in systole or diastole, cardiac tamponade, constrictive cardiomyopathy, and VSD. And so those are like the big differentials for an unstable patient, and then you resuscitate accordingly. And so when you kind of get a little more nuanced, the idea is that what are happening is that inspiration will basically reduce intrathoracic pressure, and that's usually transmitted to intracardiac pressures. And so, for example, in constriction, those intracardiac pressures will fall much less than the intrathoracic pressure because of that pericardial restraint. And so this difference in the pressure change with inspiration results in less filling to the left side of the heart, and then the reduction in the left heart filling during inspiration causes a reduction in mitral valve velocities, shifting that septum towards the LV. And so now what happens is with expiration is the opposite, right? The left heart filling will increase, and that will shift that septum back towards the RV, now leading to reduced filling of the RV of the right side of the heart. And that's how you'll get that late diastolic flow reversal and then all that venous congestion causing the patient's instability. Any questions about that? The RV pressure overload, RV volume overload, constrictive cardiomyopathy, tamponade, and VSD. Like someone was saying something?
No, don't worry about it.
All right, cool. Since Alok, you got one of them, where do you want to go?
Let's do the Iron Heart 500.
Iron Heart 500. So a 46-year-old male with refractory hypoxia on mechanical ventilator support is placed on ECMO utilizing an Avalon cannula via right IJ. The TE is used for placement confirmation. What recommendations do you have regarding the placement of the cannula? I'll give you a clue. It's not correct.
Do we need to advance and rotate the cannula?
Right on, man. Are you guys able to hear the sound effects?
No.
Oh man, it was a crowd cheering. Anyways, yeah, absolutely right. So what do you think? You want to explain what you're seeing?
I'm seeing a lot of turbulence against the wall, so I feel like it's attempting to deliver blood and also suction blood. And with the Avalon cannulas being like a dual lumen single cannula, it seems like it's just not positioned optimally. So maybe if we advance it, it might be able to flow outwardly better, and if we rotate it, it might be able to take in blood better.
So where should the flow jet be directed to?
That blue in the middle, I believe, is where you want most of it.
Yeah, so let's kind of break it down a little bit. So you're absolutely right. 100 degrees, and you want to advance it, right? So when you kind of, for those of you guys that don't know what an Avalon cannula is, right? So you have your bicable view here, right? So you have your superior vena cava on the right side. Let me just draw this real quick. So you have your superior vena cava right here, and then you have your IVC right here, and then you have your atrium here, right? And you want your jet, because the Avalon cannula, what it's doing is that it's taking blood out from the venous system and then injecting it into your RA, pointed towards the RV. So you want the jet pointing this way from your RA into your RV. So your jet should be pointing this way. But instead, because of the hole where this is, it's rotated. Instead, it's pointing almost this way. So you want to rotate the cannula so it's pointing towards the anterior side, and then you want to advance it so that the jet is optimally positioned, so that the blood is going into the RV. Now, this is a very common complication with the Avalon cannula. That's why it requires TE guidance to make sure that the outflow cannula remains directed towards that intra-atrial septum, and then the ideal, so not intra-atrial septum, it's positioned towards the tricuspid valve from the right atrium. And what you're seeing here is that it's incorrectly positioned. Does that kind of all make sense? All right, cool. Hello, nice job. What's up next?
Let's do Shockwave 500.
Shock waves 500. So the cause of hemodynamic instability caused by the pathology seen in this echo. It's 500, so it's obviously a bit far. I feel like it's unfair for all the new people because who weren't here for the last session because you guys don't get the warm-up questions. Sanjay, you want to give it a try? I see you unmuted.
Yeah, I was actually, I mean, the waveforms, it looks like you're pointing it at the tricuspid annulus there, so it looks irregular, at least on the waveform. So I don't know if it's like AFib or some type of other arrhythmia that's causing it. I'm not sure.
Yeah, so I'll break it down for you guys and give you guys a little bit of a hint. So what you're doing here is you're doing tissue Doppler imaging, right? So you're adjusting the settings on the ultrasound machine so that it's blocking out blood flow and it's more looking at tissue changes. And then you're doing Doppler through in this case, the lateral mitral valve annulus and then the septal mitral valve annulus. You guys see that okay? At the top of it, you can kind of see that you have a 4-chamber view and you have the tissue Doppler going through the lateral and the septal annulus. And then you're looking at the motion of that tissue, right? And what do you notice about the tissue is that you're noticing is that the septal annulus is moving a lot more than the lateral annulus, right? So when you look at the return to baseline, which is the orange line, that the septal one moves a lot further away than the lateral one. And is that normal or abnormal?
So
It's
are
not
you
normal.
trying
It
to,
should be
is
the
this trying to,
same. Is it an MI?
yeah, it's like an MI,
No.
yeah.
Not necessarily. I mean, it could be if you had like a lateral wall MI, but what that shouldn't cause shock unless there's like decreased screen cardiac output, and you don't see any evidence of that here. But what do I need to rule out when you see this? Because I guess like you guys know what this path. Let me say this. Which should move more? Should it be the septal wall, the septal annulus that moves more, or the lateral annulus that moves more in a normal patient?
Lateral.
Yeah, lateral, right? Because
I
it's
mean,
the free wall, not tied down to all the other chambers. And so if you have the opposite happening, what's the pathology here to be aware of is that there is, and I'll kind of give it away, there is constriction of the lateral wall, right? There's something that's causing the lateral wall to not be able to move as well and having the medial wall compensate, right? So when you look at your normal numbers, you're usually looking at between 10 to 12 for the septal wall and between 11 to 14 for the lateral wall. And there's something causing decreased movement of that lateral wall with compensation of the septal wall, right? So it's called annulus reversus. And so which pathology do you see annulus reversus in? So constrictive cardiomyopathy, right? So there is something causing constriction, usually inflammation, around the pericardium, and that's causing that annulus reversus, right? So that lateral wall is not able to move as well, causing that medial septal wall to have to compensate to try and maintain the same cardiac output. And so you'll get changes in interventricular interdependence between the two walls, and long story short, your hemodynamics changes, and then you end up having to compensate. Your cardiac output is not going to be able to be sustained as well. And so in a normal patient, once again, your lateral annulus moves a lot more. In constrictive cardiomyopathy, your lateral one decreases, right? And so your septum has to compensate versus restrictive cardiomyopathy, like we talked about in that previous question, Alok, everything is inflamed or there's some pathology going on with the entire myocardium. And so you'll get decreases in both your lateral and your septal motion. And then in case you guys are not familiar with tissue Doppler, you can notice it because different machines will do different things, but the important thing to realize is that you're looking at the changes at the annulus where you've put that marker in. Any questions on all that? Duffy? But hopefully now it's easy. All right, who's up?
Echo illusion is 200.
All right, Echo Illusions 200. This lung artifact is seen in normal lungs and can disappear as we age. So name
What
the
are
actual.
A-lines?
Yeah, so name the
What
actual
are
artifact.
A-lines?
Yeah, so what are A-lines caused by?
What is reverberation or something?
And I wish you guys could hear the sound effects. Great job, Alon. Yeah, so reverberation artifact. You want to explain it?
It's kind of like when if you go back to the image, you just start seeing the lines over and over again. There's just like that artifact going further and further down and like bouncing back and forth between the ultrasound.
Yeah, absolutely right. So what you have is two hyperechoic reflective spaces. And so what are your two reflective spaces here, right? Your reflective spaces is one is the pleural space, and the second is your ultrasound probe, right? So what happens is a beam is sent and it reflects off the pleura. And so the machine, and when it reflects off the probe again, you'll see these A lines, which are equidistant. If you ever measure them out, it's the exact same distance between the pleural space and your ultrasound probe. And because both are very hyper-equipped reflective spaces, you'll see those equidistant lines that are kind of going from the pleura onwards and more deep. And so the machine is reading it as that there is additional pleural lines, but there's nothing actually there, right? And that's something important to realize is that there's no more lines down there. It's just a reflection. And we're interpreting that artifact to say maybe the patient has a dry lung. Maybe the patient has something that the patient doesn't have overt inflammation. It doesn't mean that the lung is just, has those actual lines there. Good job, man. Oh, up, you're up.
Echo 300.
Echo Illusions 300. This artifact is often mistaken for an aortic dissection if not careful. Like ultrasound physics 101.
Is that a moderator band?
Nope. So that view, in case to orient yourself, is a TEE, and you can see it on a TTE also, but you're looking at your left ventricular outflow tract. Your moderator band would be in your right ventricle.
The pacer wire or something? No, that's like the outflow track. Interesting. What is that? Valve, like it's like a flare, like it's like artifact from aortic valve repair. No.
No, and if you guys haven't heard of this before, then it'll be hard to get. I think we went over it in our ultrasound physics lecture at the beginning of the year. Have you guys heard of a side lobe artifact? So really what's happening, right? So sorry, go ahead.
I was saying, heard it now.
So a side lobe artifact really occurs because the ultrasound beam, it's like basically you have secondary lobes picking up signals from an off-axis structure, right? So when you look at your ultrasound beam, right, in theory, you want the beam to go straight down, right? That's ideally what happens, but that doesn't actually happen, right? It's kind of like a flashlight. You send out a beam in a straight line, but while the brightest line does go straight ahead, there's also a bit of like a dimmer light that spreads out to the sides. And so what side lobes is that dimmer light that goes out, right? You guys have seen that, right? With your headlights, with your flashlight, it's supposed to go straight, but instead it just veers off a little bit and gets dimmer. That dimmer light causes that side lobe. And the reason it matters in echo is because those artifacts can mimic or obscure true cardiac structures, right? Like, and you can misinterpret, right? So if I see that and it's real, I'm concerned that this is an aortic dissection. But it can make it look like there's a normal mass and a normal clot when there really isn't one. And so you're seeing here the side beam is being sent out to the side, and it's interpreting this central structure as something that's like long and curved, but it's really just an artifact from that side beam. And so it's important to recognize these side lobe artifacts because it's just basically premise of ultrasound, right? Like every observed structure is not real, and that will help prevent diagnostic errors. And from our practice, that's obviously extremely important. Echo illusions 400. This artifact is often mistaken for an aortic stenosis if not careful. Number 400, so this is a bit difficult one. So I guess what are you guys seeing, right? I'll kind of break it down. What you're seeing is that you're seeing, Sanjay, go ahead.
Oh, I don't have an answer. I think I accidentally unmuted it. I'm not sure.
All right, so what you guys are seeing is that, right, when you look at breakdown of how color Doppler works, is that you will have the machine direct or interpret the direction of blood flow to a specific color, right? So in this case, this it's set up as like your classic BART, right? So blue away, red towards. And what you're seeing is that in your this is an apical 3 view or a apical 3 view from the TEE. So it's not technically apical, but it's a three chamber view. And what you're seeing is that from the left atrium to the left ventricle, you're seeing blood flow directed in both directions, right? When it really should be, while the mitral valve is open, it should only be going from the left atrium towards the left ventricle. But what you're seeing is that at that orifice of the valve, it's going in both directions. And so one might interpret it as, turbulence causing aortic stenosis. One might interpret it as profound aortic regurgitation. But what's really happening is that the flow is so fast that based on the machine's settings, it's interpreting it as going the other way, right? And so this is the concept of aliasing. And so what happens in aliasing is, if you guys are not familiar with aliasing, it'd be important to kind of understand what happens with aliasing just from a non-color Doppler standpoint. And maybe if you're just doing like pulse wave Doppler, because I don't know if you guys can see me, but you are sending out a signal at a certain speed. The machine is set to only be able to pick up a certain speed to a certain standpoint. And so what ends up happening is it'll detect the speed as going the other way. Another way to think about it is like, the one that you'll see in your textbooks when you study for this is like the clock example. If the clock is turning the hands at a certain speed, but I only take a picture, say every 2 hours, right? Or so let's look at the minute hand, every, minute and a half. I'm going to see the hand going here. And then when I take the picture again, it'll be like this. But what I don't know is that during that time, when I take the next picture, is that it's already made a full circle, right? And so you are misinterpreting your calculation of the change in speed because of what the machine's settings are set to. And so now you kind of go a little more advanced, and I'll hold off on that. But it's the idea of like a Nyquist limit is what you set your pulse repetition frequency to. And if the speed of your imaging signal exceeds that, or your velocity exceeds that, you're going to misinterpret your speed as going in the other direction when it's really not. And so, another example would be like, think of a car, trying to measure the speed of a car with a speedometer that maxes out at 50 miles per hour, right? If the car goes faster, the speedometer is going to wrap around and start over, giving misleading readings. And so it's the same thing with color Doppler, is that it's interpreting the speed as going the other way because it's already past the speed that you set the machine at. So it looks like there's really bad AS, but really it's just that you have to change the settings of the machine to allow it to pick up higher speeds, higher velocities. And so have some caution about that, right? Because you'll misinterpret your final diagnosis when really it's just a normal patient, normal velocities. And so I would definitely kind of build up a understanding of, the terms that you guys should be aware of, or like pulse repetition frequencies, Nyquist limits, and then aliasing. And then if you guys are familiar with like, pulse wave Doppler versus continuous wave Doppler, you will see aliasing with pulse wave Doppler. You'll see it with color Doppler, but you won't see it with continuous wave Doppler, right? Because in that setting, you put a line through your image, and you're just going to see the max frequency throughout that entire line. So you won't have the issue of aliasing. Last one. Echo illusions 500. How do I know that this hypoxic patient does not have a pneumothorax? So you have an image of the right chest and you have an image of the left chest. It might be kind of hard to see if the streaming quality isn't as good. Maybe if someone wants to walk through what they're seeing in the respective ultrasounds of the right chest and the lung chest and the left chest.
I feel like I'm seeing good lung motion on that left chest, and on the right chest, I feel like I'm seeing attempted motion. So I would
Okay.
more likely think not a pneumothorax, but maybe malpositioning of the tube.
Okay, all right. So I guess what would cause when you say malpositioning of the tube, what do you mean by that?
I mean, if it's, even possible, like a left main stem intubation, but maybe more likely mucus plugging or like atelectasis.
Yeah, absolutely, right. So what you're seeing here is basically what you should be able to identify in this image is that in the left chest, you're seeing overall, you're seeing your lung sliding, right? It's very obvious, right? You can see the ants walking on the log, right? But on the right chest, you don't necessarily see that, but you do see some motion underneath that, right? You're seeing that it's not a standstill image, that there is some like pumping underneath, right? And so any idea what that motion is that you're seeing underneath the pleura of the right chest?
Is that from the heart contracting?
Yeah, right. And so you're seeing the heartbeat, right? And what's that called?
The heartbeat sign.
No, uh, it's a lung pulse, right? And so you know that the patient does not have a pneumothorax because there's a lung pulse, and you cannot see. You're basically seeing the transmission of the heartbeat through the lungs, which is normal. But if you have a pneumothorax, you should not be able to pick that up, right? Because there's air between the pleura and the lung. And if there was air between the pleura and that lung, the transmission of that heartbeat would not go through the lung, right? You wouldn't be able to see it on ultrasound. And so it's all about ultrasound physics here. And so when you're seeing, Sanjay, I think you're sharing your screen. Nice sound speakers. And so you would not see the lung pulse. And so, one way you can kind of identify the lung pulse is you put an MO through and you'll see is that the timing of that motion will correlate with the heartbeat. And that's how you know. So it's, really to simplify it, lung pulse, it's an echo phenomenon observed when the heart's movements transmit through a motionless lung to the pleura. And you'll see it as kind of like those rhythmic movements that correlate with the heartbeat. It's synchronized with the heartbeat rather than respiratory motion. And it's because you're able to see it because the lung and the chest wall are in contact. There's no air in between. So when you see lung pulse, it essentially rules out a pneumothorax in that region. So even though you didn't see lung sliding, there is definitely not a pneumothorax. And so, being able to spot that lung pulse is a quick, non-invasive way to confidently exclude a pneumothorax without the need for more complex imaging, right? One more daily double. So based on this imaging, what would be two differentials that could be seen in a patient with this echo? And I think, Awab, you get first try because you got the answer. Close, not heartbeat sign, but the same idea.
What was the question? Like, in what setting we would see this findings?
Yeah, so like the pathology that you're seeing here is that you're not seeing lung sliding, but you know that it's not due to a pneumothorax. So in what pathologies will you see no lung sliding, but no pneumothorax? Does that make sense?
Yeah, I'm trying to think. I'm not sure. I'm gonna pass to a look.
Atelectasis, mucus plugging.
Yeah, absolutely, right? So one of them is mucus plugging, and I think you mentioned another one too.
Atelectasis. Is that what you said?
Yeah, so the mucus plugging
Hard.
causing going to cause obstructive atelectasis. Same answer.
What about like pneumonia or significant pulmonary edema?
Not pulmonary edema necessarily, but we'll get to it. Let's kind of go over it. Pneumonia
Because
could be, right? Like, so
fibrosis as well, but obviously the other lung would also be fibrosis, wouldn't just be unilateral. But that was my puppy that hit the camera button, by the way.
oh, no worries. So really the thing that I'm concerned about in this patient would be like, right mainstem intubation, really bad ARDS, which causing that fibrosis, that lung is no longer moving. You'll see with pulmonary contusions, you'll see with pulmonary fibrosis, COPD, right? Like these patients that have really, really bad emphysema, an apneic patient, right? And then subcutaneous emphysema also. So you're still able to see the lung, but you're not going to be able to see that lung movement because there's all that pathology there. So the idea is that you are seeing the right lung not moving, but it's still in contact with the pleura because you're able to see the heartbeat, right? You're able to see the cardiac contractility vibrating through. And so you have all these differentials. It's important to make sure, and yeah, the majority of the times you'll follow up with an X-ray and figure out what's going on because you obviously don't want it to be a right mainstem intubation. Does that all make sense? So it's actually part of the workup that you can do. I don't know who does this, but confirming, when you're intubating, confirming appropriate positioning. One way to do it is to use ultrasound. There's an entire protocol for that. I don't like it much because there's a lot of reasons to have a false positive and negative. But it is a quick way while you're waiting for the X-ray for you to, if you just intubate and you're waiting for the X-ray, you can still confirm placement that it's appropriately in place. And actually, a lot of anesthesiologists now will, in their training programs, to learn how to do this because they're obviously not doing X-rays in the room. They want to make sure that the patient doesn't go through the entire OR right mainstem. All right, let's quickly do final Jeopardy, and then if there's any ones that people want to go over, we can do that. So obviously we didn't keep track of points, but whoever wants to answer can just answer. This is an 85-year-old female with severe sepsis. Her clinical condition improves after 2.5 liters and pressors, but the nurse is still concerned about end organ perfusion to her kidneys because the patient has not made any urine. What is the pathology? This is a real patient, by the way.
Oh, the
Is that a
looks like the Foley's
displaced?
in the vagina.
Yeah.
Did you catch it? Is it not in the vagina? I mean the uterus.
Well, so be a little more. You can't see those structures on ultrasound, right? So what can you see on ultrasound when you're doing a suprapubic view?
I see the bladder.
Mhm.
Sure.
Is that
And what are you going to see?
potentially the rectum or the or it's her, so I guess maybe the uterus?
Yep. So
I said that. I get my points, Uday. I get my points.
well, you have to be anatomically correct, right? It's important to differentiate.
So they're a
because-
little different. Just a little.
But I said the uterus after I said vagina. I said the uterus. I did.
And so this is no good, right? This is obviously very, very painful. And now imagine trying to, what the nurse might end up trying to do is they'll try and irrigate the bladder and ouch, right? Because they might be concerned about a clot or something. That's why you can utilize ultrasound to properly confirm appropriate placement. Mike says he does have a prize for the winner based on the points that Rob sent me from last time. The person that was killing it was Syed. He had the most points in the last session prior to ending that session. So the winner of this is, sorry guys, Syed. Yeah, very impressive. All right.
What's he getting?
That's up to Mike.
Extra week of vacation.
Oh, wow. Syed is getting a fake scrub top. Wow. Congratulations, Syed. All right. Were there any other ones that you guys wanted to go over in the last 5 or 6 minutes? Any specific section? I think last time people had the most fun with the Iron Heart and the shockwaves.
Yeah, I wasn't here last time, so
We can quickly fly through some of them.
Yeah.
Which ones do you want to do?
you can just randomly go through it. Whatever you're feeling.
All right, cool. Let's do some of the shockwaves. So the likely cause of shock in this patient, and just feel free anyone to blur it out.
What is
Tamponade?
tamponade? You didn't say what is. I win.
Right. So the different ways to assess it is that you can do you put your MO through and you're basically looking for right ventricular collapse in diastole, and then you can obviously also do it through the atrium. The way you actually determine, this is something you'll have to practice, is how do you determine whether it's collapsing during diastole or systole? Well, look at your mitral valve, right? So your mitral valve should be open during in diastole, and so when you see that mitral valve open, which is that red arrow, and you see that the right ventricular free wall is collapsed, because the pressure is decreased during diastole, the right free wall collapses instead of going the other way because of the severity of the tamponade, right? It's all about pressure differences. It's not about volume. And so in this case, we don't care about the volume of the size of the pericardial effusion. We care about the amount of pressure it's causing. So in a chronic patient, you can have large volumes but no tamponade. In an acute one, you can have small volumes but high enough pressure to cause a tamponade. And then you could obviously use other methods to kind of assess, right? You'll see, you start to see like venous congestion. You'll start to see pulsus paradoxus, which is that mitral flow variation. But I'll hold off on getting into the details on that. Shockwaves 200 was the likely cause of shock in this patient. So this was a measurement of cardiac output. And what you could just quickly see at baseline is that your VTI is very high. So if you're sticking to your basic like hypovolemic, obstructive, distributive, cardiogenic causes of shock, of those 4, which one do you expect to be the cause of shock? Based on a VTI of 25.
Distributive.
Yeah, right. And so, yeah, absolutely. So if you really want to confirm, you can also just measure your cardiac output by using your heart rate times your stroke volume, and your stroke volume is your VTI times the area of your left ventricular outflow tract diameter. And then you do these calculations, and then you go from it. Keeping in mind that there's a lot of caveats to it. You want to really make sure that your pulse wave Doppler signal, that 2 lines, is in flow, because if it's off angle by more than 20 degrees, you're going to get notable changes. And then if you're actually going to measure your cardiac output, really want to use your parasol long view to get an accurate diameter. So you do have to do 2 views on our machines to get this view. Shockwaves 300. The diagnosis clinched by the Doppler imaging of the right heart. This was a bit of a difficult one. And so what you're doing is you're looking at your tricuspid jet, right? And then you're seeing that getting your TR velocity. So you'll do 4v squared. So your total velocity around here, a little more than 3, you square that, and then, oh, sorry, your max velocity, so it's about 4.1, and then you square that, and then you'll multiply it by 4. And then the other thing you're looking at is your harmonic valve acceleration time. So you're in a parastall short view, and then you just tilt it a little more superior to see your right ventricular outflow tract, and then you measure your acceleration half time. So how long does it take to go from 0 to the max velocity? And the thing to remember here is the 60-60. So it's a classic diagnosis of pulmonary emboli. So when both of those numbers are less than 60, your TR pressure gradient, which once again using 4v squared, is less than 60 and your pulmonary acceleration time is less than 60, then that's a very specific finding for pulmonary embolism. I think it's like 94 or 95% specific. Much better than using things like, your TAPC or your S prime, because those are very non-specific. And if this doesn't make sense, I would just look up a YouTube video to explain pulmonary acceleration halftime and the 60-60 sign. But definitely something you want to start doing in patients that you suspect a PE. Cool. I think we did 500. The last one was 400. 2 possible differential. Oh, we did this one. Cool. How much time we got? We got 2 minutes. I'll fly through some of the iron hard stuff. So this view is being used to guide insertion of this device. So there's a wire in your right atrium going into your right ventricle. And so, sorry, it's in your right ventricle. And so what devices do we commonly insert where you would want to see the wire in the right ventricle?
What is a PA
So
catheter?
Yeah, right. So your Swan-Ganz catheter, your PA catheter, and so it's a subcostal view, and so you're to guide insertion of a TBP or a pacemaker, and so commonly use this, right? And so the idea is that and you can also use an apical 5 view, but it's really useful because if you're having issues like, for example, a patient with massive TR, you're trying to insert that wire or you're trying to float the catheter, and then you see that it coils, right? Now you put not wire catheter, you're seeing that it coils, and you can actually visualize that in real time. And so you can actually time it based with ultrasound guidance so that you're able to get it through, and then you can actually see what the problem is. And if it's coiling up in the right ventricle, then you can realize that, okay, maybe I need to do some maneuvers to see it go into the outflow tract. And that's why I really like this view. I've definitely found it very useful when I'm having issues floating the catheter. It's the one time I've heard Dr. Dave Gerber, the legend, say that he needs to learn how to use ultrasound because we were having issues floating a catheter, and then we put on ultrasound guidance, and then we visualized where the catheter was going wrong in real time, and then made some changes using ultrasound. And he's like, you know what? I've never said this my entire career, but I should learn how to use ultrasound.
That's awesome.
Changing hearts and minds.
Yep.
I think you won the game.
Yeah.
Maybe
what is oh yeah, we did this actually. I'll try and finish up real quick. So what's the measurement being taken in this image? Everyone should know this one. So I guess what device do you guys see?
Measurement?
Yeah, what are we trying to measure in this image? Sorry, Wap, go ahead.
I said, is that an impella?
Yeah. You have an impeller in place. Someone decided to put a probe on. They obviously have some intention of putting the probe on this patient with an impeller in place. What are they trying to measure?
I know this. I'm trying to remember.
So
Yeah.
what they're trying to measure. Go ahead.
I said, yeah, I can't remember right now.
Yeah, so you think about think about mechanically, right? You've put a device in that's going to be suctioning blood out of the ventricle and trying to get it from your outflow, your inflow port in the ventricle, and then it's trying to send it out into the aorta, right? And so
yeah.
just past the aorta. And so, like, say for example, the patient's like having suction events, right? You're seeing that negative ventricular pressure.
Yeah.
What could be happening, right? It could be malpositioned, right? And this is
Yes, deep in the LV.
yeah, and so you want to make sure that the way you assess this is you can obviously visualize where it is, but if you're being very technical, is it should be a certain distance from the aortic valve based on the type of impeller that you're using. And so that's what you're trying to measure, right? Is that where is that inflow port where you see that bright 2 dots from the aortic valve annulus? And then the daily double on this question was, what is that distance supposed to be for an impeller CP? Because it's different for a 5.5. And the
3.5.
answer here is
Oh yeah.
yeah. 3.5 to 4 centimeters, and keeping in mind that for a 5.5, it's between 4.5 to 5 centimeters. Great job, man. And the last one, the second to last one was the name of this view and its purpose. I think we went over it in a different question. It's a TE view. It's one of the core views that you guys will learn. So, right, you've put it where you're seeing the right atrium, the left atrium. And then you're seeing the superior vena cava on the right side of the screen, and then the inferior vena cava on the left side of the screen. And we use it for guiding ECMO cannula insertion.
Okay.
Yeah, you want to see where everything's being inserted. And so you can kind of see like the wires coming out from the superior vena cava. It's going into the right atrium. There's another wire that's going from the superior vena cava all the way down to the IVC. And you want to make sure the wire is appropriately in place before you go ahead and advance the catheter, right? Otherwise, you can get some really bad trauma. This one was the structure is placed within the atrium to fix congenital abnormalities. If you've seen this before, you'll know it. If you haven't seen it before, you won't know it. Anyone seen this before? You'll see it a lot at high volume cardiac surgery centers.
It's a close in ASD. I don't know what the name of it is.
Yeah, nice, man. So it's a percutaneous septal disc occlusion device, and it's got this like pathognomonic 8 sign on the ultrasound. You don't see this anywhere else. It's pretty cool. And so it's basically this device that you go in percutaneously, and then it goes through the defect in the atrium. And then once it's through, you just inflate both sides, and then you occlude the disc so that it's closed. And then because of the artifact, it doesn't actually have like an 8 in the atrium. It's just the way the artifact gets picked up on echo. It just looks like that. I think it's really cool. All right, that's all I got, guys.
So
Congratulations
what's that
to
called?
Syed.
Percutaneous what?
Percutaneous septal disc occluder.
Oh, got it.
The boards like it because it's the only time you ever see it. It did show up on my boards. If you guys want to go through the rest of the questions, I'll have the recording from the first session where you guys can just hear Syed and Feba just kill these questions online. Thanks, everyone. Enjoy.
Thank you. Have a good one.
Thanks, Uday.
Oh, nice. That's awesome.